Hey Barflies, great clinicians aren't always okay. On this episode, we dive into identity, moral injury, and mental health with therapist Melissa Russiano. This is RT Sidebar. Stay tuned.
Hello, everyone. RT Sidebar on a rainy Friday. That's what it is. We're here with a wonderful topic, wonderful guests. I'm excited about this. Not the happiest, but also maybe one of the most important topics that we can discuss at RT Sidebar for healthcare providers. Today, we're here with therapist extraordinaire Melissa Russiano. Appreciate you so much for coming on the podcast. You've helped hundreds, if not thousands or tens of thousands of healthcare providers when it comes to, managing the crappy part of being in healthcare. But Melissa, I'm also excited to introduce my boss, J Dubs, Dr. Jessica Whittle, the chief medical officer here with us. We are super excited to have you, ER doc extraordinaire of everything, along with JB and Anna. We are so excited to have you. I want to jump right in because this topic is near and dear to my heart. I've been doing this way too long. And, I identify myself as a respiratory therapist, that I take care of people. I always say, Jonathan and you and I've talked about this, is how do you describe what you do to others? And I always pick on my mom because my mom thinks I take care of babies in the NICU when I play with them. That's what she thinks. And I say, you know what I do for a living? I run life support. And everybody's jaw goes, bah. Okay. They're like, holy cow. But, my identity is I save lives for a living. What's your identity? Dr. Whittle, I'm going to start with you, my dear friend. Like, what brought you to emergency care? What is it that drove your passion to do what you do?
That's a great question, and I love the passion you just in your voice when you talk about what you do. I have always loved science. I'm probably one of the most curious people I've ever known, and so then it was really a small leap to combine that with the fact that I really do care about people. You guys working for and with me might not feel that way always, but I'm teasing. But no, I think we really care about people, and when we're curious and we want to apply science, medicine is a natural outlet for a lot of us, and those are such ingrained character traits. They define us, and so it becomes very easy for your job and your identity to get intermixed. I still love emergency medicine. I love that 24 hours a day, on your worst day, we're there. Lights are on. We're ready to take care of you, and we will do it every single time. And it doesn't matter what's wrong. Someone comes to the emergency room. It might be because they're having a medical problem. It might be because they're having a social problem. It might just be that their problem-solving skills are so tapped out at that moment, they don't know what else to do. I love being the place where it's safe and you'll find an answer. Might not be your favorite, but it'll be an answer. And that is so intrinsically part of who I am, that it's a big deal to me even now. It's part of why I love doing what I do now. We think about breathing and how do we keep people breathing. So for me, that's why I love medicine. That's why I love what I do now.
JB, you and I are therapists. How do you describe yourself to other people? Like, when you see somebody on the street, you meet it for the first time. How do you tell them who you are?
Yeah, it's tough. I mean, everyone thinks, there's only two people that work in the hospital, it's physicians and nurses. So you really have to get into the details on what you do. People don't realize that, from birth to death, we're bedside with those patients. And, if you have a preemie coming out who's not breathing, that baby's probably gonna go to the therapist. And then, we might be the last person to bag and do chest compressions and before you call in the code. So that whole life spectrum, we're bedside. And I don't think a lot of people get that. But on both sides of it, the amount of stress that you deal with is immense, right? You don't want this brand new baby to die on you. And then also when you're doing chest compressions on someone's parent and the realization that they're losing their parent and that scream that's just, bone chilling, and you're trying your best, you're pouring sweat, but what do you do in those situations is very tough and emotional. And then how do you continue on for the next patient who also needs you?
There is, there's a famous quote, silly quote, if it was easy, everybody could do it. And I know Jessica, and I know Jonathan, I know you well. I know Anna, in the Army, you guys serve, and serving is this sense of pride. You really feel good during those difficult times to, reach the other side and do the very best that you can. But does it cause some injury on your insides? Is this something, it's not everybody could do this, but is there a bad part to this identity of who you are? Jessica, you want to start us?
Yeah, I think anybody in healthcare for more than about 5 minutes will tell you that there's downsides. But
Mhm.
something Jonathan said resonated with me. You're there and you're doing everything you can. You're tapping into every resource you have, and people die. And one of the things that I think is most difficult is people who go into healthcare tend to be high achievers. They tend to be really driven, really highly motivated. And here's the problem. Human mortality, it's 100%. Every single one of my patients is going to die. The only question is it today? And so there's a constant negative feedback and sense of failure when we do. All the pomp and circumstance says we save lives. No, we don't. Not one. They all die. And how do we deal with that conflicting information? And how do we not internalize a sense of failure about the nature of the world? And for me, I've been able to change my perspective on this. And it was actually through the help of mental health care and through talking with a counselor and a therapist and things that I was able to come up with. And you guys have heard me say this all the time. We don't save a single life, but we can reduce suffering with every interaction that we have. And when I began to remeasure myself, then suddenly there was a chance for success. And I think that's why today's topic is so important, right? Is because that's what you can do about mental health. You can't really change the fact that people die, or that COVID happened, or that relationships are hard, or all the things that we live with in a broken world. But we can change our perspective. We can change how we measure, and then we can begin to make different choices resulting from that growth. And that's what reaching out has been able to do for me.
Melissa, I want to come to you because I know on your website, because I've been on it, I've reached out to you myself, personally, because I've had some struggles. One of the things you talk about is exactly what Jessica just said, is perfectionism. We as healthcare providers try to be perfect. But our measure of perfection, or our goal of being perfect, might be conflated. It might be a little so how can you build upon what Jessica just said when it comes to that perfectionary perspective?
No, I think that's a really great point. And I appreciate what Jessica just stated, but I think it's having realistic expectations of what's in your control. A lot of the individuals that I work with, the first thing we do is kind of establish this locus of control. What is 100% in your control and what is not. And when you're able to really concretely differentiate between the two, that is when you can start healing and reframing your view on your work to the point of saying, okay, I can still do great work in areas that are out of my control. I just cannot control the outcome. And it's that wisdom and that peace that comes with accepting that you cannot control everything. And if we would sit down and talk to any healthcare professional listening today, and say, do you think you can control the outcome of all their patients? They're all going to look at us and say, absolutely not. No, I can't. But I think internally there's this drive that we can cognitively say, I can't control the outcome, but there's an internal drive to be like, but I could really try. And it's in the really try that it starts kind of breaking down that individual from the inside out. Because if you truly look at a locus of control, what's fully in your control is very small. And it's very hard to wrap your brain around for a lot of individuals that are high achievers, overachievers, and perfectionists.
I think that's really interesting because I wanted to bring this up because this is something that we have barflies that are not clinicians. Okay, I'm going to say that right off the bat, Anna. That will make you happy. I know it because we see them on LinkedIn. There are people that don't understand the magnitude of death and dying that some of us see. So when I'm thinking critical care, nurses and physicians, ER, nurses and physicians, every respiratory therapist in the hospital, the chance of them seeing death is exponentially higher than others. It's just how it is. But when we want to save lives, we put that metric of saving lives as the goal. We're going to save your life. Do you guys, and I'm asking all of you guys, do you guys think that that is what has been contributing to some of our moral injury when it came to COVID? Is that the risk of death was so much higher for us perfectionists that we can't get out of what we want to control everything in healthcare, but this one we couldn't, and it got out of control. Is that what you think happened with COVID and what we saw in our ERs and intensive cares? Melissa, I want to start with you because you get to see the perspective from everybody.
And I was just going to say, I'm going to defer to bedside first, but I will respond. I'll respond to that from my perspective. And I take it as like, I'm almost on this macro or meso level viewpoint because I was able to see it. I don't want to say after the fact, because I worked with a lot of individuals in the muck of it. But I was able to see it from a higher level viewpoint. So I'm going to be curious to see on that boots on the ground view as well. But I think it was the magnitude, but I think it was like the rapid fire that went on. And a lot of articles and research is really paralleling COVID to a war zone in a lot of these medical centers and hospitals, and the impact on an individual's abilities to psychologically rebound when they're not getting a break is where I think that disconnect kicked in. There was no time for healing. There was no time, because as soon as you had one situation, there were 5 more waiting for you. And as soon as you dealt with those 5 more, there were 20 more waiting for you. And there wasn't that ability to kind of wrap your brain around it in a way that healthcare workers very uniquely do. There's about outcome, there's a death. You usually have time to pick yourself up, kind of heal slightly, and then tackle the next issue. COVID didn't allow for that.
Anna, I know you just leaned forward. I know you have a thought.
Well, I think similarly in COVID, what made it so complicated is you would, and correct me on this, you're experiencing so much stress, and then you're going to leave the hospital and you're going to go to Walmart and people aren't going to wear a mask. And you have just experienced so much, and then you leave. And that's actually kind of similar to like the drone pilot who leaves that training, their trailer in like Arizona, and then goes to Walmart, who's just experienced so much stress, and then goes out into the rest of the world and feels very alone and very isolated. And so there are some parallels there. And now again, that question of healing in the aftermath is,
I think.
Go ahead.
Sorry, last question. Actually, I forgot about this. A barfly actually reached out in the form submission and said, please start talking about this. And I just remembered that while you're speaking, that a barfly actually had contacted us to have this conversation today. So you're not alone if anyone's listening to this. Like we got this request a couple of times.
Jessica, talk about your experience. You and I have chatted a lot. Like, tell me about your experience of what it was like, that war zone. Did you feel that war zone mentality at a point? And what, how did it feel? Tell us your perspective. Tell us your story.
I have probably a little bit of a unique story and perspective on COVID. So before I went into medicine, I did my PhD in viral infectious disease, and particularly in respiratory pathogens. Right. So then I became an emergency medicine physician. So pretty much I had been literally thinking about a COVID type event my entire career. That is what I had been preparing for and thinking of. And so I jokingly say that in February of 2020, I sent my husband to Costco to buy several cases of toilet paper, and I'm the only person I know who didn't run out. So and he died laughing when he's like, I'm just doing this because I love you, but I don't understand. 2 weeks later, he's like, you are like Nostradamus or something. I said, no. So I had a unique thing. So on the one hand, I felt so excited, not because I wanted bad things to happen to people, but I was so excited because I was like, this is everything about me just getting to maximize my potential. I had residents working for me. I could teach them, I could coach them, I could help keep them safe. I was managing the COVID plans for my son's school. I knew how to keep people safe. I knew how to translate the data. I was sending out, emails and all around the country to people and my friends and family who were like, you're the only person I know who can read the literature and tell me, so tell me what to do. And I, in one way, was like at my most, to use a psychological term, most self-actualized, in at least from a career standpoint. I didn't mind the death and dying. That's what we've all trained to do. I don't think that's what wears on us. There are some patients I've struggled with over time and needed to process differently. But even the legions of people waiting wasn't the problem. The problem, and this is how I actually think it parallels the military often, the problem was the betrayal. The betrayal. The fact that my administration didn't listen to me in February and get masks. So then when it happened at the end of March, when I told them 6 weeks later it was going to be there, they didn't listen and they didn't act. The fact that my religious community, and I come from the South, which has a pretty strong religious culture. My religious community, who I identified very strongly with, became part of propagating poor data. The fact that I had other healthcare workers who said people trying to develop vaccines were somehow maliciously. My whole career was spent on how do we develop vaccines to save people's lives, and I had other healthcare workers look at me and say they're trying to kill us with these vaccines, or they're trying to track us or do terrible things. You're calling into question my character, and I was betrayed on every side. I had patients who were fighting with me. I had coworkers who didn't read and process literature well. I had a religious community that felt like it, in some ways, some of them turned against me. I had media that I couldn't trust. I had a government. I have a friend who has a great quote. She said, we worked in a government lab together, and she says, since working here, I've lost more faith in the government than I ever knew I had. Right. I had this sense of betrayal by our leadership, by our country. And that's what hurt. And
JB, yeah.
You're probably going to need to edit a lot of that. I know that was longhand. Thank you. Sorry.
No, that's exactly, the passion that we have to see, because I don't think people truly understood what we went through. JB, you were an administrator. Did you have that sense of wartime? Did you have that same sense of betrayal, or in a different way? Was your perspective really any different than Jessica's? Tell us the story.
Kind of. I mean, in a sense, I was the betrayer, because as an administrator, I'm the one to blame, right? But it was a tough time. I was the executive over quite a few departments, but two of which are respiratory and infection control, right? These are the main ones. And then also I was over quality and risk. So for the environment, I have to create an environment. But I was bedside during H1N1. We had a lot of
Yep.
deaths during H1N1.
Mhm.
It never felt like this. And it never felt like this because, you would have deaths in the patient rooms, but then you can come back to your break room or the nurse's station and decompress and do all this stuff, right? But we actually screwed that up in the sense that if you go back to the break room, now we have these big plastic dividers. You can't use the microwave. You can't do this. You can't do that. You have to sit apart, only two people in the break room at a single time. In the nurse's station, you're like cubicles with plastic everywhere, barriers, all this. You can never get away from it. And that was the one thing that I noticed was the big change was there was no place to decompress. When you walked into that hospital, it was in your face all the time, nonstop. And that's on top of the scale of deaths, right? So you're as a healthcare provider, you're used to death, right? You get one or two a day, but now you increase that scale, and then you're in an unfamiliar, unforgiving environment. You're being asked to do things that you would not normally do, uh, and so then really like it's just that stress builds up upon you, right? So like I've never had to reuse my N95 mask. Now I have to. Now, I would have employees that would take their N95 mask home with them and steam clean them. And then, you that's an issue, right? Because then if you degrade the mask, then it's not working. And then, there was a lot to it. And, from an administrator point, I will say that I was the betrayer in the sense, but in being the executive over these departments, I was getting emails from the White House. I was getting emails from the state. I'm getting emails from the Department of Health, county public health, right? And everyone has all these things that, and they would change from day to day. They would conflict. How do you make everything, how do you become compliant when you have 4 and 5 different agencies that are telling you what to do? And then the next day or the next week, they change their own stuff. And then, the hospital's got 2,800 employees. How do you educate all 2,800 employees to this? It just wasn't. So, I had to have some self-realization that I'm making these people crazy, and they have to provide care to the patients. So then I became the buffer. And so I would get all these changes and I would say, okay, well, this is irrational. Probably not going to do this. And I'd start
Mhm.
slowing it down. But yeah, from an administrator point, I do understand why they did the things that they were doing because you have all this exterior pressure that you also didn't have. But if this were to happen again, I think really that environmental pressure that you would put on healthcare providers, I think is what compounded this thing on top of the scale of deaths and stuff. At the beginning, we didn't have our treatment plans down like we did towards the end, but that there's that. But the external pressures, there is nowhere to decompress. There is no way to get away. When you go in there and everyone's there for like 12 hours, right? 8 to 12 hours. When you walk in, you're on. And so when you leave and there was no time to catch your breath between those 8 to 12 hours, you're more wiped than you have ever been in your career. And that compounds when you're having to do it repeatedly for a couple of years. And I think that was just one thing that I've noticed going through COVID that I found to be the most stressful.
So it's interesting. So two different perspectives, one common theme: isolation, and it sucks. But you both said two words, and two words I want Melissa to comment on. Jessica said betrayal. Jonathan said unforgiving. What do those two words mean to you as a therapist that take care of us? Like
Mhm.
those two words are powerful words. What does that
Absolutely.
mean, and how do we manage those two words?
Yeah, those are two words that hit at the core.
Mhm.
And another word that I would add to that is guilt. And the word guilt is, I think, maybe a little loose, because I can't think of a better word right now, but also given all of this betrayal and unforgiving, and then knowing you're going home to your families and not really knowing what kind of impact that's going to have on them too, and feeling guilty for not showing up as a mom, a wife, a husband, a
Mhm.
sister, a brother, because A, do I know what germs, I'm bringing in, and B, I have no bandwidth left because of the betrayal and the unforgiving on the day. And so then it just cultivates sort of this internal cycle of this negative view of self, which then starts to degrade. And when
Mhm.
betrayal is present, betrayal can be worked through, but it comes with a process. It's almost this restorative practice process, but that means that the other party has to admit wrong. And I think that's the piece that was missing in a lot of the scenarios that I've talked about, with individuals is, well, my administration, my hospital, my supervisor, my fill in the blank just said, oh, it's COVID, just deal with it. And so there's no ability to accept responsibility. And truly, is it anybody's responsibility? No. But the way it was communicated and processed could have been done in a healthier way. And so then it's dealing with betrayal without being able to have resolution.
So, Melissa, were we set up for failure? We talked about, we have healthcare people that want to be perfectionists, but yet you have to say you're wrong. It feels like we're set up for failure. Like there's nothing we can do about it except fail. Would you agree?
In this scenario, I believe that there would have been a very small percentage of success given all of the things that were stacked up against. So absolutely. Now, does that mean it's detrimental and there's no hope? Absolutely not. Because one thing, if anybody who's ever met me, there's always a silver lining. There's always something to be learned, and there's always hope. But in this scenario, I think given the multitude and magnitude, as well as the timing, I'm not quite sure there could have been a different outcome
Yeah.
at this point.
Hmm.
Melissa, so how do you help your patients, or how do you
Mhm.
help your patients then work through that um, betrayal and guilt and unforgiving element, and the fact that they will never likely get someone who will admit the wrong, who will say like, yeah, we did wrong?
That's rough, and as much as I know each of you have talked about your struggles, I am the first person as a mental health clinician who's been doing this way more decades than I will admit, is that therapists are human too. And I can think back in my life on times that I've been betrayed, and just, those feelings of, but I didn't do anything wrong. This was the position I was put in, and just that feeling of helplessness. And so the first and foremost thing that I do when I work with individuals is the ability to recognize and sit in that space. And nobody wants to sit in that space. Nobody wants to feel those feelings because they're icky and they're not fun. Like, we want to avoid them like the plague. But in order to get true healing, it's about ripping the band-aid off and saying, okay, I need to look at this as objectively as possible. And then I need to start grieving what I wasn't given or the opportunity I didn't have. And once we can get that foundation built, then we can start rebuilding in a healthy way. But it's really hard to kind of be in that space to say, I'm never going to get the answers I'm seeking. I'm never going to get the apology. I'm never going to get the, oh, you were right. I should have listened to you. I'm never going to get any of that. But in order for me to move forward, I have to be okay with that. And for people who are overachievers, high achievers, perfectionists, to be okay with something that's substandard that could have been done better is like the kiss of death. Like, really? You want me to accept what? But if you don't accept that, you will constantly be held hostage by that.
So when you say sit in that space, how do you get someone in that space? And what does that mean to sit in that space and
That's
feel
such
that pain?
therapy language, isn't it? My apologies. I try to avoid therapy language. Initially, I think when working with somebody, especially who has been dealing with all of these moral injuries and has gone through everything that the last 4-ish years have been for us, is I'm very interested and curious in hearing their story. How did you get here? What drew you? Kind of how we started this morning. What brought you into your field of choice? What gets you out of bed in the morning knowing that this is your 4th 12-hour shift in a row? Like, let's talk about the passion, and then let's see where you're at now, and let's go through that journey. And so a lot of it is understanding their story, learning their story, and then starting to be able to identify those points where that impact was had. And then looking at it, we all tell each other stories. I am a huge Brene Brown fan. I've been certified in her work. So I love to say, yep, Dare to Lead, great job. I love to say I speak Brene well. But to use one of her favorite lines is the story you're telling yourself. And a lot of times when we've been impacted at different points, we're telling ourselves a story that could be 80% accurate. It could be 20% accurate. But to be able to go through each one of those, I use a timeline sometimes, and it's like, I don't need to know what dress you wore for your first day of kindergarten, but on your timeline, hit the high points. And with healthcare workers, on your timeline, hit the high points of your career and the low points of your career. And then we look at each of those and decide what is fact, what is fiction.
Mm-hmm. Jessica, thoughts?
Yeah, well, I just wanted to point out that this was actually one of the things that Melissa helped me with. As an ER physician or anybody, and to most of our barflies out there, you're trained to react, to do. And Melissa started with, well, what did that feel like? And I realized I could only name about 4 feelings. I didn't even have a vocabulary, much less be able to say I feel betrayed. I just knew something was wrong. And I had an instinct to go fix, do, but I didn't know what that was. And so before I could even sit with feelings and experience them, I had to be able to name them. And just like it's so powerful for a patient when you can tell them what's wrong, they can deal with it once it's been named. One of the things that professional mental health can help you do is begin to name things, because then you can categorize and then you can work forward and move through this path. And that's one of the things that was most powerful for me and has continued. And the caveat to that I want to point out is that that's a learned skill. So maybe you had spectacular formative family and a village around you where someone could vocalize this as a child. I didn't. Probably they were better at it and maybe I missed it. I don't know. But somewhere I didn't learn those skills. And so just like if I don't know how to manage my blood pressure, I go ask somebody who knows how to manage blood pressure, right? And I learned there's people who know this. I didn't know how to experience, name, talk about, process, or what to do with feelings. And so, but they're a part of human existence. I couldn't deny that. I tried for a lot of years. Didn't work. So then when I reached out and I found that there are people who that's their specialty. And that's what's so powerful. And I think that's what Melissa and her colleagues offer to all of us.
Melissa,
Yeah.
are there other differences that healthcare workers, when you were treating, because you are a therapist specifically for healthcare workers, are there other differences like what Dr. Whittle just mentioned of how you're trained to act and do? When you're training them, are there differences than I don't want to say like normal population? For example, I could see a healthcare worker really struggling to be on the other side of the bed and to not be asking you a ton of questions and wanting to like help
Mhm.
you and to I could see there's probably other differences that we could probably highlight here that might encourage, hey, go and seek help,
Mhm.
go and get the language.
Right.
I'm curious what your experience is like as a therapist.
Yeah, no, I think that's an excellent question. And I appreciate Jessica's comments because one of the things, as much as I joked about, well, that was a very therapist statement of me to say, hold that space for somebody. One of the things that I try very hard to do when I work with individuals is to take the lingo out of it. There was a comment on my website and I just updated it. I'm pretty sure it's still there because I would fight for it. Is if, I'm not the kind of therapist that's ever going to say, and how does that make you feel? Because if somebody asked me, and how does that make you feel? I'd literally throw a pillow at them or disconnect the video call. Because if I knew how it made me feel, I wouldn't be talking to you, lady. So like, why are you asking me that question? So I think with all of the providers I work with, I strive for two things. A, to treat you like a professional, because you're very educated, you're very skilled, and you're very accomplished in your field. And it is not my job to take any of that away from you, nor would I even want to or try to. And so I'm going to try to talk your language as much as I'm able to. But B, to start refilling those gaps, because you can be brilliant in your field of choice and lack the understanding or the knowledge of how those internal emotions that you've been able to shut off for your entire career, which is what makes you a fabulous physician, therapist, bedside nurse, fill in whatever your role is, that makes you excellent at what you do, but then it almost betrays your humanity. Because and as a clinician myself, I think early in my career I thought, well, I can just deal with trauma all day long, I can deal with heavy stuff all day long, and then there's a light switch, I'll just turn it off, go home, and I'll just be human, and I'll show up for my baby girl, and and I'll just be me. Well, newsflash, we're not built that way. There is no light switch. 30 plus years into my career, I haven't found the light switch yet. So it's about teaching folks, how do you have that balance in your language with your schedule? And so it's not like, I'll give you a prime example. I know we're not talking about burnout today, but at one point in my career, many years ago, when I was a CEO of a company and I was debating, do I still want to do management or do I want to go into private practice? And I had a physician telling me, well, I'll just give you lots of meds. You can keep doing what you're doing. I am a huge proponent of psychotropics. They've done fabulous things for my clients. But I'm not going to take medication solely to stay in a job, because the job can change. Once again, locus of control. I can control where I work. I went to see a functional med doc because I was like, there's got to be something I could do naturally. And she said, you're burned out, take a year off. And I looked at her and I said, I'm a single mom. My kid is 8. And you're telling me I'm going to pay you $275 an hour with all your supplements and all your meds, and I'm going to take a year off. Like, that's not realistic. And I think because of that experience that I had, was very clear that if I'm going to partner with somebody who could be burned out, who's dealing with feelings of betrayal, who's questioning what they're doing and why they're doing it and how they're doing it, I need to step into their world and find tools and techniques that are going to work within their lifestyle slowly, because I will never tell somebody to take a year off of work.
Melissa, so what did you do?
I told her she was crazy and I never talked to her again.
Well done.
Well, I meant what did you do regarding your burnout? But I mean,
I resigned from a position of management. I was running a company with 125 employees, and I just went full time into private practice and teaching, and never looked back. And it took some time of being very intentional. And I think that's why I'm so passionate about this area and partnering with other folks, because I realize that with intentionality, with making some hard choices, that maybe other people are going to look at you and say, well, why the heck are you doing that? Like, that makes absolutely no sense. And by prioritizing my health, that you can still do good work ethically and clinically, but not have to take a year off in that process and still maintain your humanity on the outside. It can be done. It takes a lot of work, but it can be done.
so and actually correct me on this one, I stuttered before on whether or not to say patients or clients. Do you have a preference? Do you have clients?
It's interesting. When I'm dealing with healthcare workers, I call them patients. When I'm dealing with other folks, I call them clients. Whatever, whomever I'm speaking to, whatever language they use, I use. Because as far as I'm concerned, I'm dealing with another human that has some sort of crack that they want to bridge, heal, fill in. And I don't care if they're a patient or a client, they're just a fellow human that I want to help heal.
Dr. Whittle, did that help you at all to be like, I'm wearing a patient hat? Like when I see Melissa, I'm putting on this hat.
I'm trying to remember. I don't know that it. I don't know that I ever registered being sort of called one or the other, but I definitely recall that when I would when the camera would come on, we would start we were going to have a session, especially at the very beginning when I was I had a lot of conflicting. I just had a lot of emotion. I didn't exactly know what was going on. And I definitely remember when that screen would come up, that I very quickly actually developed a sense of, it was a relief. That became a visual trigger for me that I knew, okay, here was a space for a few minutes that I was going to be okay and I wasn't going to fail. And no matter what came out of my mouth, it was going to be okay. And Melissa, was, and she changed the way that I treat my patients, because I wanted to have this, I wanted to be able to create that emotional space for people around me too. And she let me cry in front of her. She let me curse. She let me make horrible, terrible, dark jokes. Butler's mentioned that, we tend to do this in the hospital, right? That's one of the ways we cope. And she would laugh with me. She just let me be that. And so I don't know if I was a client or a patient, but what I was somebody who was a little bit broken, who needed some guidance on how to fill that. And it's not actually just filling a crack. I would argue what it is a reshaping of yourself in a new hole. And or at least for me, one of the other things that really resonated in what I just heard you say was kind of talking about balance. And this is probably the other key thing I learned out of all of this. Certainly when I met Melissa or other mental health providers I've worked with over the years, we all talk about balance, but I keep stumbling over the same block, which is I keep thinking, okay, I achieved balance and now I've checked it off my list and I can go do the next thing. And the only problem is tomorrow I'm unbalanced again, right? Like that it's a constant process. And I also think that is something really hard for people in healthcare because we like to tend to be a bit more linear thinkers. Not everyone, of course, but we like to do something, get it right, and then move on to the next goal and the next achievement. And balance in our lives is never that. And so I find myself still struggling with the pendulum of and taking myself out over my limits and then coming back and having to constantly redo it. I think I do it more efficiently now than I used to, but it's still a work in progress for me.
I'd like to just jump in for just a quick second because something like I had a big realization. I had an aha moment yesterday. Is when we were talking, getting prepped for this, Jonathan and I and Jessica, Anna, Melissa, this is what we were talking about. We were talking about like we don't have a skill set for this. This is why we come to you. This is why a respiratory therapy leader, or respiratory therapist, like we don't know how to be in that safe space. We do not know how to ask for help. We don't know how to, because we're Teflon. That's why we crack jokes in the trauma bed. It's the reason why. It helps us create some sort of small happiness in a very horrible spot. So we don't know how to do this. So, as a podcast for respiratory therapy leaders by respiratory therapy leaders, this was my aha moment yesterday. I asked Jessica, I said, Jessica, during med school, did you get some type of training about mental health and about caring for yourself? And her answer was, it's part of the curriculum. I turned to JB and I said, did you get anything in respiratory therapy? And what he's doing right now is exactly the response that I got. And I'm sitting there going,
Sorry, no one can see that or hear it.
oh, that's right. Okay. So he just kind of giggled and laughed like, no. So when JB, that was something that like really jumped out at me. Like, we don't have that. And respiratory therapists go to every code, every trauma. Like we don't have that. Like we're told to be Teflon on the outside. We go to all these classes, these leadership classes. Hey, you must be Teflon, but we're literally rotting on the inside because we don't know how to stop the rot. We don't have that skill set.
In the military, I can't think of one mental health class. We would just be, here's resources you can go to. Like if you have EAP, we had EBH. It's like send your soldiers here. So like an HR perspective. But like, yeah, that is super interesting, Max. Sorry, keep going.
But we don't, I went to Melissa. I went to my friend Jessica. Jessica, I'm having a problem. I can't seem to let COVID go. And she goes, you need to talk to Melissa. I'm like, I talked to Melissa because I didn't know how to let it go. But here's the thing. I was never taught it in the first place. So how am I even going to know where to go or how to go or what to go? I don't know what to do.
Matt, what do you think? And Melissa, I'd be curious about this. What is the role then of shame? Right. So we're supposed to be the answers for how to be healthy, but no one taught us how to any of these skills. I got a little bit of it in my curriculum, and it's increasingly, I think, in med schools and residencies, people are beginning to be part of the curriculum, but certainly not in all, and certainly not in, as you mentioned, RT school, nursing school, and things. People aren't discussing it. So then, are we too ashamed to say, "Wait, there's a whole big gap in my skill set for being healthy, but also in that skill set for being human," as Melissa brought out, your humanity and managing it. And for me, I know that there's a lot. I struggle with those issues.
JB, do you remember your first death? Or do you remember a student that had their first death or a new employee? And you're like, attaboy, you'll get him next time. Like, that's literally what happens.
So, as much death as I've seen in the hospital, I still remember my first death very vividly. I was in housekeeping. I was in the ER, I was taking out the trash. I pulled a curtain to grab a trash can, and there was a 13-year-old girl. She had like matching pink pajamas. She had her hair braided. She had little ladybug clips in her hair, and she was completely mottled, and she hung herself from a bunk bed with a belt. And so that was like my first touch on this. And this is no healthcare background, no healthcare education, no tools, no nothing. And so, how do you deal with that was pretty tough. I talked to quite a few people about it. But, it becomes a gaping hole in your knowledge when you're, for example, RTs do a lot of terminal extubations, right? So you're there with the family. How do you have a meaningful conversation with them about their feelings and their coping mechanisms when you don't have the tools? You were never taught the tools. And even after you graduated, I know every hospital I've ever been in, they don't offer tools, right? I mean, you can give tools as for yourself, but how do you take care of those family members that are seeking that help? You do have chaplains, but not everyone's faith based. But how do you have these meaningful conversations? And that, I guess, that became a very, and you guys brought it out of me in this conversation. But looking back, that is a gaping hole in my clinical school that just wasn't there, and I could never actually have those really good conversations with people that I just terminally extubated their family member. And now what, right? I mean, I'd like, I'm very sorry for your loss, and then have to like sneak out of the room while they're all crying and everything. And that could have been handled better, but I didn't know how to handle it better, and I was never really taught how to do that. And I think, from a curriculum standpoint, that is something that our clinical schools can do better with.
Agreed.
Yeah, let me even jump into that conversation, because Jessica, I think the concept of shame, going back to my comment about Brene Brown, like shame is something that I will zero in on. And I would say 98% of the individuals I work with have some element of shame that has been a barrier for them getting treatment, or the reason that they're seeking treatment. But it's also not taught in mental health curriculum on how do you take care of you and how do you seek out help, which seems so backwards. And so I consistently teach grad classes, which sometimes it shocks me that they let me, because I have probably the most unorthodox version of doing therapy, but they keep inviting me back. But one of the things I always stress with the future therapists of the universe is you have to take care of yourself first, because with my caseload being comprised of mental health professionals, medical professionals, I think we take 2 or 3 sessions just to normalize, like, hey, I'm glad you're here. Like, you're the healthy one for seeking this out. Because there's a fear of, you're going to report me and my license is going to be gone. I'm going to lose my job. Or for anybody, like, you're going to say that I'm not ethically like conditioned to be able to still be practicing. I've never done that in my career. I don't foresee ever doing that in my career. I mean, never say never, but there'd have to be a really crazy circumstance for that to occur. I think it's the individual that seeks out the assistance to say, hey, something's broke and I can't fix it on my own. That shows way more strength. But there's a lot of shame for at least those first 3 sessions, and probably a long time leading up to making that first phone call of, I can't fix this. I fix others, but I can't fix me. What is wrong with me that I can't fix me? And I have heard that from every single medical professional I've worked with, whether it's via a joke, haha, you must think I'm a horrible physician that I can't even figure this out, or, oh my gosh, you're probably wondering how I can treat patients because I'm a horrible mental health therapist. Whether it comes out via sarcasm and joke, or whether it's explicitly stated, every single person I treat has an element of shame of, I can fix everybody but me.
Wow.
So is there too an element of validation that they might be seeking? Like, do they want to hear from you? Perhaps, like, we started this episode saying, like, great physicians aren't always okay. Like, you're still, you can still be a great physician even with that. I guess I'm wondering to the listeners right now, is there something that yeah, is there a way we can like validate their experience?
Well, I very quickly would want to hands down say that you can do amazing work and touch and have an impact on thousands of individuals and still not feel okay internally. Like, they do not have to be mutually exclusive, that, you know, you're fully healed internally, or, you know, you can't be a good physician, or you can't be a good respiratory therapist. I think there's this element with individuals of, if I see a lot with workaholics, if I continue to fix everybody around me, eventually I will feel okay inside. And it's kind of like chasing that feeling of, I just have to work harder to be okay.
Ooh, this sounds like codependency too.
Well,
I
just
clearly experienced what you're describing and still struggle. And one of the things that helped me was getting the language to be able to say, wait, am I working so hard because I just am really driven and I just really love this stuff and I have this great curiosity, which I mean, you can see I have respiratory support machines behind me. I do experiments at home, because I do. It's fun. I enjoy it. And that's a healthy reason to be engaging. But I have to pay attention to myself to realize when I'm engaging because I'm avoiding the areas I don't feel as confident, like being a mom, or being a good wife, or being a good friend, or dealing with my extended family, which is exceedingly complicated at times. Right, but we all have those things, but I don't always feel as accomplished, or I don't get the same dopamine hit from those other things sometimes. And so I have to say, well, why am I working as hard as I am? And I think, this process helped me understand that, and it continues to be something. So I agree. I think people in healthcare are remarkably good at hiding. I also think they're remarkably good they're very well trained. So you can be good at your job because it actually doesn't require you engaging in it fully in order to carry out the motions. But there's not a lot of joy if you're not fully engaged.
Right.
yeah,
JB.
yeah, no, I was just thinking about it and thinking about why. And I always think about like The Sopranos, right? This very strong figure went and sought out help, and everyone kind of like judged him on that. And as a healthcare provider, you are the rock that everyone clings to, right? Now, if I seek help, does that mean that I have cracks showing in me, right? And so I liked what you said about, you are the healthy one when you actually seek help, right? But I think socially, most people think the reverse. There's something wrong with me. I need to be this strong rock that everyone clings to. I shouldn't have these cracks. And I think there needs to be a little switch that flips. People just need to think of it the other way around, because really, like, when you're in healthcare, you have to be, that rock. You go in, your patients are relying on you, family members are relying on you. You can't show any cracks, you can't cry, you can't do all this stuff. But then if I seek help, does that mean that I am cracking, and is that healthy? And I think that would be, just thinking back to all the people I've worked with, I see that could be a barrier.
Yeah, absolutely. And I know we're running on time here, but I wanted to give a very quick analogy, sort of as my wrap up for our conversation, which I have a feeling is going to continue after this, is that I give to almost everybody I work with. And that's, to look at the concept of marble. And, I recently remodeled a kitchen in my house in Pennsylvania and really wanted to put marble countertops in until I went and priced them. Anybody priced marble recently? Like, Yeah, no, let's consequently to say I live in Tennessee and there are not marble countertops in my Pennsylvania kitchen. Sorry to my amazing renters on that. But marble is beauty because of its cracks. If there weren't cracks and divots and imperfections in marble, it would just be another slab of whatever. You can tell I'm not in masonry. It would be another slab of whatever. Marble is expensive, exquisite, because the cracks are what makes it beautiful. So you have your choice, is that you can look at that slab of marble and you can shine it up and you can make it beautiful and you can make it work for you. And it can be the most exquisite, expensive material that you have. Or you can shove it away and say, oh, there's too many imperfections in that. That's where the beauty comes if you choose to embrace it.
Wow. So, Melissa, thank you for telling me I'm beautiful, because I have lots of cracks. No, but that is a great analogy. What I got from today is, those cracks are beautiful and we don't know how to fill them. And we have to, it's a skill set we just don't have. And we need, and it's okay. It's okay. I kind of suggest that all healthcare providers that deal with this high stress should have that skill set. And whether that's you, Melissa, a therapist that's out there, a website that can help with, some meditation, whatever it is, everybody needs to have that skill set to deal with this. And I love that Jonathan kind of called out our profession. Like, hey, when you're in education and teaching respiratory therapists or med school or nursing school, like this needs to be a priority. Jessica, any final thoughts today?
Only a couple, and that is, life's too short to be ashamed or to not really be fully present. You only get a few days on this earth, so be whole. And if you don't know how to do it, if you don't know the skills, there's people who specialize in that. And there's hope. We used to think that your brain never changed. Now we understand we can change it dramatically. It grows. It's not a static thing. You're not damaged forever. It's just part of who we are as we grow and expand. And we could do that, and you can take an active role in it. And there's people who can help you. So do that. It's worth it. You'll be happier, and then you can be so much more to the people around you. My last thing I just want to say is thank you to Melissa and to all of the people like her out there who are just letting us embrace and fully experience and be everything that we can be as humans, and bringing our humanity back to this crazy workspace where that's really what it's all about.
JB, you want to give us a final thought before we hand it over to Anna to finish us off?
Yeah, I just kind of listening to Jessica and reflecting, but it is bringing the humanity back. You have to realize that you are a human. And just like if you're a respiratory therapist, someone came to you for their breathing, you're a human and you have these feelings that, like I'm like Jessica, I probably can only describe 4 feelings in my, I have no vocabulary for it. But there's a specialist for everything, and seek it out. I mean, that's the healthy way to manage yourself, because you can't help others if you can't help yourself.
Excellent. Anna, want to finish this off?
Yes. Okay. So Dr. Whittle started the conversation with all my patients are going to die. The question is when. And then she ends it with like, yo, we're all going to die. The question is when. Don't live in that shame. And I just love like this like full circle element of that, and this sense of like suffering is how we actually can live the most fulfilling and rich life possible. One that isn't just driven towards happiness and this like happiness trap of, right, like I just want to be happy, but no, like I want to live a rich and meaningful, fulfilling life. And so that includes suffering. So like love that concept. And then I'm so hyped up on storytelling. And so like hearing Melissa talk about like the story you tell yourself, and I know this sounds so crazy, y'all, but like I have not read Brene Brown, and I know that's like off brand for Anna, but the story you tell yourself and like what's fact and fiction. And Melissa, in my head, you're like a coach that while the client is going through that storytelling process, you are coaching them on the language that they should be used, the language that they're telling themselves, and you're helping them, one, get their awareness skills with language, and then next would, I think, be through that grieving process of that old sense of self, right? Because Dr. Whittle said like the sense of identity that you're kind of grieving of who you were before and then who you are about to become. And that's like a really, really hard process. And then accepting that. And I don't think we got to that final part of like, how do you accept that, right? We're figuring this out in real time as we're telling our own stories. And we're, you know, sometimes us barflies, like we're stumbling along as we're trying to figure this out and telling these stories and this healing process and all of that. So I totally think about all those elements in the show. And I think this is so great and important to talk about. And it feels very reaffirming that like we're on the right track towards something elevating. Like I didn't like, oh my gosh, how do we not have mental health as part of the education process for respiratory therapists? Like, excellent question. Why isn't that on like the AARC like agenda? Like, I don't know, like I was just throwing that one out there. Like I've gone to so many conferences and like I haven't seen that as a subject or topic, like throwing that one out there. And here we are, let's elevate it. Let's have this conversation. We're going to keep it going. So September is Suicide Awareness and Prevention Month. And Barflies, you've requested this. We haven't talked yet about like burnout. We haven't talked yet about a leader. Like, what do you do when your teammates, you're noticing changes in productivity or, and that's kind of like that HR element too, that we actually maybe get training on. So we were debating bringing an HR person on the show. So anyways, register for at vtherm.com/RT sidebar. You'll get email updates from me when we have Melissa back on the podcast. We were debating a live Q&A session on 21 September, if that interests the Barfly community. But yeah, that you just register with the link in the show notes, vtherm.com/RT sidebar, and then we can continue this conversation forward. So Matt, those were like all my thoughts.
As always, I love this. It makes me feel good inside. It makes me feel good that we have like-minded people trying to care about, you know, moving our healthcare profession forward. So I just want to say thank you to all the barflies out there. I want to encourage all the barflies to take care of themselves, take care of their families, take care of each other. Realize that you don't know everything and you don't need to be perfect. All you need to be is be you, be that piece of marble that is specific of being you. So thank you guys so much. We're going to skip some shout outs today, but we're going to get to them soon. We love you guys. We love you, barflies. Keep being awesome. Until next time, Anna, take us with the fun music that I like to dance to.
Vapotherm does not practice medicine or provide medical services or advice. Any clinical recommendations provided herein are solely those of the speaker. Practitioners should refer to the full indications for use and operating instructions of any products referenced before use. Palvichko, Hayes, Whittle, and Butler are employees of Vapotherm, and our guest is not compensated.